Any practitioners who've been part of a well-functioning tumor board will tell you that this makes their job easier.
There is no substitute for having all of these specialists together to focus on patient care case by case.
People coming together in teams who bring a variety of skills and knowledge to best decisions for patient treatment.
When we first heard about the MCC program starting, we were concerned that this was yet another job foisted upon us where we were going to have to attend a number of rounds that was going to take a lot of time for preparation without a lot of benefit to us. And so we divided up the work so that it would minimize the impact on each radiologist. But as we started attending these rounds, we found that they were interesting, that they were helpful, that we gained a lot of information from the rounds, and now we divide up the work so each of us actually has an opportunity to attend these rounds.
It gives the community urologists an opportunity to present their patients directly to us, and that has meant often faster access or fast tracking of patients to get them in if there is an urgent condition that needs our attention. And we also are able to promote and highlight clinical research studies that their patients may be eligible for.
MCCs are based on good evidence that if we bring together teams of professionals involved in the care of cancer patients together, and when they consider together the issues that are affecting an individual patient's treatment, that the outcomes for those patients on the whole are better. And so we've undertaken, based on that evidence, to have an effort to institute MCCs across the province for cancer patients in all of our hospitals that are providing cancer services. Today, we know over 56 hospitals now participate or host their own multidisciplinary case conferences. And the patients that are discussed are from every disease site. We know that in 2010-11, for example, only 37% of them were conducted according to the standards, and I'm very pleased that this has now grown. When we look at last year, 2012-13, 56% of MCCs now meet the standards. So I think we're right on track to meet the target by 2015 that 80% of MCCs across the province will meet the standards criteria.
There are many challenges with implementing MCCs across the province. However, what we've found is successful, or helps with success, is identifying an MCC coordinator, identifying an MCC chair, and seamless video conferencing technology.
An MCC chair has to understand the culture of their particular MCC. The ability to fall on your sword and to demonstrate that we can bring forth issues, discuss them collegially, is key to deriving the most benefit from your tumor board.
The role of the coordinator, I would really kind of compare to being like the glue that holds all the processes together. So it really provides administration, support, management, so that everything will be as seamless and as effective as possible.
The technology has to be there, and you have to have strong leads like we have in the Barrie Centre to facilitate this process and make it easy for us rural surgeons to become involved.
We've been very fortunate that we have an OTN coordinator, so they're able to support the round. So if there's any technical hitches, she can be that lead on that.
Over the past 2 or 3 years, this has become quite a seamless process where the physician simply has to go to the designated room and the system is up and running. The physician who is remote can see radiology, all the imaging, can see pathology, and can hear and see the people discussing the case.
Finding a time that's beneficial to everybody, that people don't have to go to the OR by 8, just making sure that we can get a time that fits with the community and the regional partners, because everybody is important and everybody needs to present cases.
Royal Victoria Hospital in Barrie began MCCs in 2006 when we had one combined MCC with GI, breast, and melanoma that met every 2 weeks. Today we have breast, prostate, hepatobiliary, GI, thoracics, lymphoma, and endocrine MCCs, all of which video conference to hospitals throughout our region, including Collingwood, Huntsville, Bracebridge, and Orillia, in addition to partnering via video conference with Odette, Princess Margaret, and St. Joseph's. We now have 40 to 50 people coming each week from all disciplines, including allied health, nursing, and palliation.
Nurses and allied health bring a different perspective to MCCs. Our role is to speak to patient issues, such as emotional, family, and socioeconomic factors that may impact patient care management.
As well, it provides a teaching opportunity that is attended by our trainees that include medical students, residents, and fellows.
I know more about how difficult a pathologist's job can be than I ever did before. The pathologists understand a whole lot more about what the clinician needs. So we understand each other's jobs, our roles, and what we expect of each other in a much greater depth than ever.
The pathologists at any MCC play an essential role on integrating and many times translating knowledge to clinicians. In many instances, we have changed patient management because of our input, even when pathology was not the main focus of the discussion. We pathologists play an important role, whether talking about biopsy indications or defining primary versus metastatic disease. That's why I think it's time for us to get out from behind our microscopes and be directly implicated in cancer care.
I think there really are benefits for the radiologists. Not only do they see that where their reports need to be very specific and which items they need to stress in their reports, but also the rounds give them an opportunity to get some follow-up on patients. So often in radiology we see a case, we make a diagnosis, we make a recommendation, and that's it. We never see the case again, and so we get some continuity.
We have seen numerous occasions where the plan from a solo practitioner, well-intentioned, is modified dramatically by the input of a multidisciplinary team. And you recognize when you watch that individual case that a patient would not have received optimal care without the tumor board.
When I first met with the patient, I had indicated that this probably isn't going to be a curable situation. Coming out of the MCC discussion was that we actually agreed on a plan that would potentially cure this patient.
Working in a rural hospital, one could feel isolated. Attending MCCs allows me to feel connected to our medical community. I feel this improves my patient care. Decisions are from a multidisciplinary perspective, and overall, I feel better about providing care for these patients.
My medical oncology colleagues are in the room, and it's also important that I get a consensus from them because it's not always obvious what the medical oncology plan should be.
I think we all derive a lot of satisfaction and a lot of confidence in knowing that we're bringing the best care back to our patients and that we're supported by our colleagues.
I think the evolution and refinement of these in recent years has been one of the most important breakthroughs we've had in caring for cancer patients.
I think the results that we have seen in terms of the progress we are making, they're really a testament, I think, to the dedicated, enthusiastic work in perseverance of Multidisciplinary Cancer Conference chairs, the coordinators who support them, and participants throughout every region who've come together in a very positive way, I think, to participate in this consistent, high-quality way of delivering care for our patients.
As the burden of cancer rises, more patients
will need to be discussed at an MCC.
Each region
Each region has made tremendous progress in making MCCs an integral part of cancer journey.
We can all work together
Together.
together
to improve the quality of MCCs across Ontario.